everyone. Welcome to Newark Community Health Center's 6th Annual Women's Health Symposium. Isn't it great to be here? And is it great to be alive? It's just absolutely wonderful. So hello to everyone. As you know, NCHC always hosts our annual Women's Symposium every year. But of course, due to COVID, like many things, we're not able to do so. So we're just so excited to be here. We have some amazing people who are going to speak to you today and to let us know what is going on in terms of legislature and also on clinical practice. And so as we go through today, we will be hearing from Congressman Mikey Sherrill. We'll be hearing from our First Lady, Tammy Murphy. We'll be hearing from Mr. Dennis Gonzalez, who is our Acting Regional Director and Executive Officer of the U.S. Department of Health and Services. We'll be hearing from Senator Cory Booker through his representative, Ms. Hannah Morey, and we'll also be hearing from Mayor Dwayne Warren. Now, unfortunately, because today is election day, we'll not be able to have two people. But they sent they're very sorry they weren't able to make it. And that's Lieutenant Governor Sheila Oliver and also Senator Sandra Cunningham. And we will not be seeing Assemblywoman Cleopatra Tucker. So they do send their apologies because it's a great election day and everybody is paying attention to the races. So thank you so much for taking the time. We do apologize for the delay, and we're going to have an awesome day today. Do remember that for the Women's Symposium is in two parts. We're going to have the first part where we talk about the political issues and what are our elected officials doing for women in the community. And then in the afternoon, we'll be hearing from clinicians talking about some of the issues that women face and how they're able to address it. So do remember that America and the great state of New Jersey are the best place to live. Wouldn't you think so? We think so. The people are given all of its civil liberties and the ability to live our lives of our own choosing. However, we are threatened by healthcare disparities faced by a certain group of people. As you know, healthcare disparities faced by one group is a threat to all groups of people. The statistics are known and it is not a secret. The data is told by many experts in all media. We know it by heart. In 2019, white infant mortality rate was 2.9 per 1,000 live births. Black and Hispanic infant mortality rate were 8.5 and 4.5 per 1,000 live births. That is some serious statistics. Now, NCHC's goal for early entry into prenatal care is 80%. What it means is that we make every effort to try to not just care for women of childbearing age, but we encourage them to take care of their bodies and to make sure that that when they're pregnant, they can begin to get prenatal care immediately. Now, our goal is 80%, and we're currently at 77%. So we still have some work to do in the community. Another goal we have is to look at or to lower the rate of low birth weight babies that are being born by our women. Years ago, we had a goal at 3%. And for the last 8 years, NCHC was able to maintain that 3%. However, last year and this year, we had to increase the goal to 6%. Why? Because we found out that in the last 2 years, the number of low birth weight babies being born by women was rising. And so we had to set a realistic goal. And our goal this year is to try to keep the birth of low birth rate babies at 6%. We really would prefer 3%. And so our elected officials are here today. And I want you to know that they're not just collecting and analyzing data, but they're doing something about it. And today, you're going to hear directly from them about their actions and their plan. We also going to have on our panel an exciting group of people who are going to be introduced by our moderator, Dr. Pamela Brooks. Now, she's no, what should I say? She's no stranger to us. Dr. Berg is a board certified obstetrician gynecologist and is affiliated with Hackensack Meridian Health Rarity Bay Medical Center. In 1984, she graduated from Douglas College with a BA degree majoring in biology and sociology. She received her medical degree from Rutgers Robert Wood Johnson Medical School and has been in practice for 25 years. Dr. Brugg is a faculty at Rutgers University in the Department of Obstetrics and Gynecology and Reproductive Science. She also serves as faculty in the Division of Advocacy and Outreach at the Rutgers Robert Wood Johnson Medical Center Women's Health Institute. Amazing, isn't she? She has received numerous mentoring, teaching, and community service awards throughout her career. And her interest in disparities in healthcare has led her to address Black maternal and infant mortality, and especially in New Jersey. Dr. Berg is the founder of the New Jersey Black Women Physician Association. That's why I say she's no stranger to us. The nonprofit mission of that association is education, advocacy, and mentoring. Founded to address Black maternal health disparities, in particular, Black maternal mortality. So presenting the organization today is Dr. Brooke, who is going to moderate for this morning, and we're going to lead after that into some presentations from our elected official. So without further ado, I'd like to introduce Dr. Brugg, and then we will be presenting the videos from our elected official, Dr. Brugg. Thank you so much.
Thank you. Can I just sit here?
Well, yes, but can you, can we move the microphone?
No, I can stand up, don't need to worry.
There you go.
Thank you very much. Thank you, and thank you for having me. It's been always a pleasure of being here. Your health center is always on our list of people that are working within the community to address the issues that we address as an organization. So thank you, and thank your organization for the work that you're doing. I will start off by introducing our panelists for today. We will have a few discussions and questions after the videos. Our first panelist is Ms. Hannah Moore. She's the State Director for the United States Senator Cory Booker, managing the Senator's offices across the state. In this role, she oversees the day-to-day operations and staff, as well as long-term strategic initiatives based on Senator Booker's policy and advocacy priorities. Ms. Moore began working for Senator Booker over a decade ago at his nonprofit organization, Newark Now, and then for his mayoral office in the city of Newark. In 2013, she joined Senator Booker's first U.S. Senate campaign, where she helped develop his statewide and federal policy platforms. After a successful campaign, she joined the senator's staff. As counsel, her policy expertise spanned everything from criminal justice reform to healthcare to immigration. A graduate of the University of Notre Dame and the University of North Carolina School of Law at Chapel Hill, Ms. Mori is admitted to the bars of New Jersey and New York. Then we have I have to call her a colleague, basically. She has worked for the past 2 years diligently with our organization as the representative for the Community Health Center in all our initiatives that we're doing in regards to disparities for COVID-19 and the impact it's had on maternal health. And that is Ms. Angela Ramos, the Healthy Start Program Coordinator for the center. We will now have the videos.
Hi everyone, this is Congresswoman Mikey Sherrill. I want to thank Newark Community Health Centers for inviting me to speak to all of you today. Over the past 2 years, Newark Community Health Centers were on the front lines of fighting the COVID pandemic. New Jersey was hit early and hard in the spring of 2020. When our community needed help, NCHC members worked tirelessly to respond to emergencies and ensure people had access to the health care that they needed. The healthcare workers and staff of NCHC have made and continue to make incredible sacrifices to keep New Jersey healthy. Their bravery and grit deserves the wholehearted support of the community, and in Congress, I'm working to ensure they continue to have the resources that they need. Like all of you, I believe that every New Jerseyan should have access to high quality, affordable care. And in order to improve health equity, we must strengthen access to women's health care. I was proud to vote for the Women's Health Protection Act, which would secure the right and improve access to reproductive health services. I'll continue to stand as a strong voice for women's access to health care. Just a few weeks ago, I proudly voted to cap the cost of insulin at $35. It's unacceptable that the soaring cost of insulin forces hardworking New Jerseyans to make the difficult choice between filling a prescription for insulin and putting food on the table. I've spoken with constituents who have had to drive to Canada to get affordable insulin, and that's simply unacceptable. I'll continue to be a strong advocate for bolstering access to affordable health care, and I look forward to working with Newark Community Health Centers in this effort. Thanks again for having me. Take care.
Hello, everyone. This is First Lady Tammy Murphy. It is my honor to welcome all of you to the 6th Annual Women's Symposium organized by Newark Community Health Center. And I want to thank CEO and President Dr. Pamela Clark for the invitation to the program. As Nurture NJ continues its work to combat New Jersey's maternal health crisis, we are incredibly grateful to count partners like the Newark Community Health Center as allies. Our shared mission requires dismantling the racism that has seeped into every corner of our society and prevented underserved community members, especially women of color, from accessing resources and living in communities that allow them to simply be healthy. Although challenging work, the Nurture NJ Maternal and Infant Health Strategic Plan is our blueprint for achieving this goal and includes recommendations for every sector that touches a mother's and baby's life, including health services, transportation, nutrition, housing, and more. I am thrilled to share that a little more than a year from the release of our plan, we have already begun work on more than half of the plan's over 70 recommendations. And with the support of Newark Community Health Centers and Nurture NJ's incredibly committed partners across the state, we are on our way to ensuring every mother and baby in New Jersey gets off to a healthy start. Together, we will make New Jersey the safest and most equitable state in the nation to deliver and raise a baby. Thank you.
We're gonna start off with the first question for each of our panelists, including Dr. Yes. The most recent statistics have New Jersey ranked as the 4th deadliest state to give birth. From both the national level and on the local level, how have you seen COVID-19 impact maternal mortality? But also, what initiatives have you undertaken or are continuing to support in order to address the impact of COVID-19 on maternal health? We'll start with Ms. Moore in regards to on the federal level.
Sure. So I think the question focused a little bit on Essex County, right? Those are some of the statistics
Yes.
I mentioned, and I think it's important to note that New Jersey is one of the most densely populated, is the most densely populated state in the country, right? And Essex County is one of the most densely populated counties within the state. So, thanks. As I was saying, it's important to kind of, set the context as Dr. Berg has, which is New Jersey is the most densely populated state in the country, and Essex County is one of the most densely populated counties in New Jersey, right? And so that we know that even with the kind of astonishing statistics for the state, it is inherently more exacerbated in this county because of the demographics as well. And so, the federal government has looked at this problem from a number of ways. Under COVID-19, we were able to make some progress on a lot of legislation that Senator Booker actually sponsors, right? And so you have a number of things, which I'm sure we can get into more as the program goes on, but you have the omnibus bill, which Senator Booker reintroduced last year in this Congress. And that is a package of 12 bills that comprehensively looks at exactly this problem of maternal health and infant mortality. And so, that covers everything from incarcerated women to technology to coverage for things like doulas and that kind of thing. And then more recently, what we had some success with was with Senator Booker's Mommy's Act. The Mommy's Act is a bill that Senator Booker introduced, and it would extend Medicaid coverage for new mothers. So right now, or historically, the coverage for after a mother gives birth is 60 days on Medicaid for those women that are eligible for Medicaid, and mommies would extend that to 1 year. That is, some of the most important, the most critical time for a new mother and her infant, for them to have access to all of the critical services that they need. And so, the bill not only kind of extends it, but it enhances the services that are covered under it to include things like doula. And so under the American Rescue Plan Act, which we passed as one of the COVID relief measures back in 2021, that did accomplish exactly what our bill had proposed, right? It was incorporated into that plan, extending it to 1 year. And it also gave states the option to extend that coverage once that expires for an additional up to 5 years, I believe.
Thank you. I would like to ask Ms. Ramos the same question, but in regards to what is specifically happening here at the health center. Thank you.
Thank you, Dr. Brooke. So here at the health center, we've seen over 200 pregnant women so far for the Healthy Start program itself. And we've seen a lot of women very hesitant coming for COVID-19 vaccinations because they're not so sure what is it to the effects of the baby afterwards. So we continue to educate on and enforce the vaccine to them. But we also make sure that they're comfortable, that they are, they have all the tools that necessary to go into this birth, even after. We've seen a lot of women who had COVID after giving birth. So we are making sure they are coming back for the postpartum visits, making sure that the babies are receiving their well child visits as well. We are giving them all the necessary tools afterwards, like nutrition, education, their mental health statuses, because we've seen the rise of mental health with our pregnant women as well. And a lot of them are just very scared. They don't know where to go. And having services like Healthy Start here at the health center has proven very effective for them. And they are very appreciative of the services we are providing to them.
Could you give some information about the Healthy Start program for women that don't know anything about the program?
Sure. So the Healthy Start program is a free program for the community. We deal with pregnant women, non-pregnant women, fathers, children up to the age of 18 months as well. So we, if they need help with health insurance, signing up for health insurance, we're able to provide those services for them. All of our staff members are certified ACA, Affordable Care Act consultants as well, so they can do that. We have our doula services here, the fatherhood program, we have centering, we have our registered dietitians and our OB providers here as well. So we're a full circle. They need anything, we are here for them. And if we can't provide it here, we do refer out to other community organizations like the Community Food Bank, SNAP. We help assist with applications. So anything they need, we are here for them.
Thank you for asking that question. I think it's an amazing question to ask. Thank you. And I love the fact that we had Senator Porter's response first, and then you got it straight from the person who manages our Healthy Start program. And so Newark Community Health Centers pre-COVID served 51,000 patients each year. And then as of March 2020, when we got into the COVID pandemic, we found that in that year, the number of patients here dropped to 45,000 patients for that particular year. So what we did experience in the first couple of months, which was like March, April, May, is that we normally see 12,000 patients every month. And by April, we were serving 9,000 patients, and it went down to 5,000 patients. And so, and then the number of monthly patients went back up to 10,000 patients by August. What that is telling you is this, that for the early months of the COVID pandemic, everybody was afraid. And so people were concerned about coming out, leaving your homes and coming to the health center. However, that short drop in the number of patients was only for a short period of time because there was a great need for our services. So it tells you that even though people were afraid and were hesitant in coming out, they did turn out because healthcare is no respecter of persons and COVID. People need to come to the health center. And because of that, Newark Community Health Centers from March, actually, through the help of the federal government, and of course, Senator Corbett was very helpful. We got PPEs very early. So by the end of March, we had all the PPEs we needed. We had masks, we had the all the done in the gowns, everything, because we didn't know. There was a time where when I saw a doctor, I couldn't recognize her because she had on, you know, that covering that you use when you're going to surgery over your head. She had that on. She had on a face shield. She was wearing glasses. She had on the surgical mask, and she also had on an N95. Then she had on the gown, and then she had on the booties. Would you recognize anybody? And so we were very prepared. We had to be prepared because we realized that we had to keep the health center open. And I'm going to tell you, we have an amazing staff here at NCHC. We never had an issue where we didn't have enough providers and nurses to see our patients. So you have to be grateful to our healthcare heroes here at NCHC that despite the pandemic, people came to work. And then through the help of the federal government, come on, Mr. Gonzalez, you can sit right here.
Okay.
And I did apologize because we always change, right? Don't we just change due to COVID? We know how to adjust and change. And so Mr. Dennis Gonzalez, who represents not more than Region 2, but HRSA, and is right here today. And it was a little delayed. It's not just you wait because today's election day. So a lot of people couldn't make it and are delayed. And so COVID has taught us that we need to change and be flexible. So you see how flexible we are, you just stick yourself in and we're going to keep going. And because that is what COVID has taught us. And that is good for our mental health. Because if we don't change and learn to be flexible, and not only that, to adapt and to keep moving because life continues, then we're going to have a serious problem with people with mental health. And we are NCHC. We are healthcare and we do take care of people, so we take care of your mental health. So that's why, you know, you fit in quite nicely and we're all just going to move on. And so I would just say thank you to the federal government for giving us those PPEs so that we're able to keep the health center open during COVID. And we got enough PPEs. And then most importantly is that when we had to reduce the dental staff because they couldn't work because of the COVID and the impact of the equipment that they use. So we had to close dentistry and only keep 2 dentists for emergencies. But we had to keep the health center open because the pregnant women had to come. And so healthy staff spent the time. We had to keep on communicating to the people. The health center is open, you've got to come. If people miss their prenatal care, we call them to make sure that they come in here. So the long and short of it is that through the help of the federal government and the state of New Jersey, we're able to get all the PPEs we need to keep our staff safe. And we have an amazing group of staff that work here who are dedicated and they came. And due to that, we kept the health center open and the visit count went down slightly, but it went back up because NCHC cannot close this door, COVID or no COVID. So that's the response to the question, and I think you're going to ask Mr. Gonzalez.
Yes, I'm going to ask you a different question, though. Welcome, and thank you for being here. It's much appreciated. What factors come into consideration when agencies are planning in preparation for the next COVID-19 outbreak? So what are we thinking of? What are things that we, as our own organizations that we represent, can do for the next outbreak? Yes, please.
Thank you. Good morning, everyone. Actually, good afternoon. My apologies. Pam, Dr. Clark knows that whenever I do an event for Newark community, she holds her breath because there's always something going on with me, some kind of drama, some kind of, it's always an adventure for me. And so today was one of those days. So, but here, healthy and in good shape and in one piece. So the question is actually a very good one. And you can see that here in Newark Community Health Center. One of the reasons that Pam and her team here were able to continue to serve the community is because they were prepared as a health institution, as a health facility, to continue to provide the services. Because one of the things, especially when it comes to a pandemic, you can't shut down, as Pam was saying earlier, you can't shut down healthcare. That's when you need healthcare the most, is when people are getting sick because of a pandemic. And we at the federal government, we want to provide the resources to our community health centers to make sure that they can continue to function. Hopefully we won't have, these pandemics are every 100 years. So, the next one 100 years from now, and I don't think I'm going to be around. But we we want to make sure that if this ever happens again, that our community health centers and our hospitals have the resources that they need. And in terms of funding, we invested billions of dollars into our healthcare infrastructure all throughout the country. We want to make sure that notice how quickly we were able to produce the vaccine. Within a year of the pandemic starting, we had the vaccine, the therapeutics, the medicine, and all of that it takes the whole of government approach, but also with our providers, healthcare providers, and with our the business community, the private sector. We wouldn't have been able to do this, of course, without Pfizer, Moderna, Johnson & Johnson. So, and actually few people know this, that back around 10 years ago, HHS started to plan for a pandemic because we knew that, the time was not in our favor in terms of, the period between pandemics. The last one was in 1917, the Spanish flu. So we started about 10 years ago, maybe even longer, to plan just in case. And what we were afraid of at that time was the bird flu, which was wreaking havoc in China and in Southeast Asia. So we were planning back then, and that planning was useful for us when this hit. It was a different type of virus, it was a different type of flu, but the concept was the same, which is to provide the resources to make our community, our providers in the community who are on the front line. And Pam, I want to thank you and your team, because this was very difficult. These last 2 years have been extremely difficult, especially for the frontline healthcare workers. The ones, it's easy for me because I was in an office, so I was working from home, but for all of you who had to, work with the patients, who had to risk, your own health. So that's where we want to make sure the resources go, and I think we've done a good job. Yeah, there have been, there's always room for improvement. But we're very pleased with what we've been able to do, especially because of providers and facilities like Newark Community Health Center.
I would like to. Pass it down. Thank you.
Thank you. And completely agree with everything that Dennis just said. And from a senator's perspective, our job is really just to fund his work through appropriations bills. But I think it's taught us, these past 2 years have taught us so much, right? Dennis mentioned Dennis mentioned the frontline workers, the healthcare workforce, the folks that work here at NCHC, that we are all forever indebted to, right? And let's not forget also who they are. I know everyone can't see who's in the room right now, but the majority of the people in here are women, and it's indicative of the fact that over 70% of our global healthcare workforce are women. Hence the emphasis on the healthcare services women need. it's not just maternal health, right? It's also access to, primary care doctors, and Dr. Clark mentioned dental services, right? That's something that is extremely expensive, especially here in the state of New Jersey. It is, mental health services. We've seen the repercussions of mental health services after a pandemic in which people were on lockdown for months at a time. And what that kind of, what that means is still kind of manifesting itself. And I think we're still seeing it play out. It really highlighted the fact that New Jersey specifically, not just our country in general, but New Jersey specifically, is something of a mental health care desert in some places, right? We know that the reimbursements under Medicaid are insufficient for that coverage and to incentivize more doctors to come in and provide those services. But one of the positive things I think we learned about is the power of virtual healthcare, telehealth, and for years and years we've been talking about telehealth. And I remember touring this facility years ago and seeing Dr. Clark's brand new telehealth room, but no real guidance on how we were going to be able to use that in the future because of the obstacles that that CMS regulatorily has on reimbursement for telehealth services. And I think you'd be hard pressed to find somebody today who hasn't had a visit with a doctor that is over the phone or virtually on camera or something like that. And it's really, I think, going to be key to expand healthcare services to people who are in rural areas, sure, and there are definitely rural areas here in New Jersey, not just across the country, but also to people who, are working, sometimes working multiple jobs and just don't have the ability to get to a doctor's office and, spend all of the time that entails. So on a lunch break, you may be able to have a consultation with a doctor virtually, and that's something that we finally, when put up against the wall, CMS figured it out, and it's a reality for most people that I think we don't want to see go away.
Okay. I'll speak on more of the community level, our patients here. So dealing with pregnant women, it's hard for them to see a provider with telehealth, right? Because providers can't really listen to their fetal heartbeats. So like Dr. Clark said, we had to stay open for our pregnant moms. They needed to see their OB providers. And there is a shortage of OB providers, so our OB providers are worked, but we also have many women who need the help. So I think during this pandemic has shown us is that there's always something unexpected going to happen, right? So you just have to roll with the punches and deal with what's there. Where there's a will, there's a way, and that's what I felt we did here as a Healthy Start team, as Newark Community Health Centers. We took everything one step at a time to ensure that our patients were well taken care of and they had the services that they needed. And we did the best that we can, and I think the community itself is grateful for that and for our services here.
Awesome. And I'm glad you mentioned that you did a tour years ago when we were experimenting with telehealth. So through the federal government and HRSA, we got monies to experiment with telehealth years ago, and we had it all set up, but we still weren't ready for using telehealth when it finally came, because the people were not many people were using it. And so now we have to encourage more people to use it, and they're not familiar. The people who we serve like to see the provider face to face. They like to see the nurse. And so we had, in the very early stages, we got funding from HRSA again to add more telehealth service. So we got more laptops, and we ordered the software company to give us an easy way for us to connect people. And so I think that worked tremendously, but people were thinking, oh, this is not a visit.
Yeah.
You know, I need to see my provider, even though you're seeing the provider on the phone. And there were some people whose cell phone was not capable, so they have to do it just by a phone call in the early stages. But later on, we found out that a lot of people had smartphones. You know, in the early stage, we thought that people would not be able to see; they could only hear. And so that never stopped us from doing the telehealth, whether you could see or you could hear. But later on, we found out that people do have smartphones that they can see. And so they will do the telehealth visit, but they were just concerned that they weren't actually in the exact room. But we have made great strides because coming out of all of that, it taught us a different way to do telehealth. And we believe that in the future, and I'm going to go back to the federal government and to HRSA, especially go to HRSA, and we're going to come back to Senator Corabuca, that I believe that every patient who is registered at an FQHC should be given a member's kit or a patient kit. What that kit is that it should have blood pressure cuff, it should have a thermometer, it should have a tape measure. I'll tell you about that in a moment, and you should provide them with a scale. And that is a kit that I believe that every patient should have to take home with them, because you need those things for a telehealth visit. It would help the patient, the provider, even more if they had, because you'd be surprised people don't have a thermometer. They would call you and you would see on the phone that they have a fever. But how does a provider really know what the temperature is? Somebody may think they have a fever, but they don't. And so if had a proper thermometer at home, they could actually stick it in the mouth and the provider could watch. And when they take it out, they show it to the provider, so that's proof. Same thing with the scale. A lot of people don't have scales. And especially for the pregnant women, we wanted them to come in. But say, for example, on that day they had an issue. We would have loved if a pregnant woman had a thermometer so we could take their temperature, a blood pressure cuff, that they could take it, and we got a grant from the federal government that gives us blood pressure cuffs that allows us to remotely connect and get the information directly from the blood pressure cuff. Thank you to the federal government for that. And then the scale. And we need the scale to get a true weight, because you know how we are as a people. Do you really know your true weight? So when you ask somebody how much weight, they're gonna tell you what they wish to weigh. And the provider needs to know the actual weight. So if they had the scale, we wouldn't have to get the wish list for the weight. We would actually see it. And finally, for the pregnant women, we realized that a tape measure would be helpful in their kit, because they could measure the belly and we could get some information. So we have learned a lot from telehealth. We're grateful for the funding from the federal government. We're grateful to Medicaid to pay for it. But most importantly, that's the next step in telehealth, in that it would be good if every patient got a kit.
Yeah, and I think adding on to that, there could be some funding also for actually having fetal Dopplers. I mean, right now you sell Dopplers in Walmart. You know, the patients would have to be taught how to use them, but there's instructions, there are videos on there. So that's something else to consider to add on to the kits, the introduction kits for pregnant persons that are coming through. Now, going back to our concern in regards to maternal health, with new variants, unfortunately, on the horizon, how are your agencies and organizations preparing to meet the needs of birthing people and infants in the face of this evolving virus? We can start with you. No, you're fine.
You want to start, Pam?
I think it's fine. No, go ahead, yes.
Yeah.
By the way, it's nice to see you, Hannah. I didn't reckon you had these masks. So, even before the pandemic started, and this is very sad statistic, New Jersey, for all its wealth, it's such a sophisticated state. We have some of the best hospitals, some of the best doctors in the country, in the world. Yet New Jersey has one of the highest maternal mortality and morbidity rates in the country. It's hard to fathom that, to grasp that, because we're so, we're so sophisticated. You would think that maybe, one of the Midwestern states or one of the southern states would be worse than us, and actually they have better, and many of them have maternal outcomes that are much better than New Jersey. So we need to, recognizing that in our region two, we started to work with our partners. And by the way, New York is just as bad. I mean, it's just so hard to believe that New York and New Jersey have such bad maternal health outcomes. So we've been working with our partners in both states, health departments, and our community organization, community providers, to address some of those issues that make it a problem in these states. For example, transportation. We know that a lot of pregnant women don't have the access to transportation that is necessary for them to get to their doctor's appointments, or to get to, to take care of their healthcare needs. There is an equity issue also. We have, the numbers, as bad as the numbers are, they're worse when it comes to women of color, to Black women, Hispanic women, which is, unacceptable. So we want to make sure that we are addressing the equity access issues among pregnant women. The resources in terms of Medicaid, to make sure that the dollars are there. One of the things that we worked with New Jersey on, and this was done last year, excuse me, last October we did this. So, once a woman, when she's pregnant, she doesn't have insurance, she's placed on Medicaid. But then after she has a baby, that's it. Well, New Jersey doesn't do that anymore. Now the woman stays on for the whole year, for 365 days. And that's something that we worked with the governor and with the Commissioner of Health to make sure that gets done here in New Jersey. And it's hard to believe that it didn't happen before, that it took, that we had to do this in 2021. But see, these are the things that we've been working on, these small little things that when you add them up, they make a big difference. And that's what we're trying to do. And of course, we wouldn't be able to do this if not for our partners at the state and local level.
I'm sorry, I forgot what I was
saying. No, it's in regards to the variants that are coming up and the impact of it on pregnant persons, and what type of initiatives or programming or legislation we should be doing to.
Got it. Thank you. I was just so engrossed in Dennis's response. The variants, I think, are a reminder to all of us, right, that we are still very much in the midst of a pandemic. And, as happy that everyone is to kind of see people are able to engage in those activities that they haven't been able to for so long, and to go out and go to school and that kind of thing, which is important, again, not just because the country needs to go on, but because mental health was really took a turn during the pandemic, and these are the activities that are important to that. But they are constant reminders, these variants, that we have to remain cautious. And so from the federal government's perspective, while we're able to relax some of the mandates, and the president had the authority to do that. So he was able to relax some of the mandates with, when masking is concerned and whatnot. The CDC is still very much engaged in constantly researching what are the safest recommendations that they can make for state and local health departments to follow. There's constant research that's happening. I know not just through Dennis because it's under HHS, but because we continue to fund it. So there's, it's incumbent on all of us, and the federal government appreciates that to be vigilant. We're also, studying what are some of the long-term effects of COVID. I think we're starting to see that, and it's a question as to whether it's certain variants are more prone to producing long-term effects than others. And this is all research that's happening right now because we do see that long-term COVID is something that is impacting a significant number of people, right? And if it's 1%, if over half the population catches it, that's huge. And so there's a really exciting study that I know the CDC is working on right now to kind of study what causes that, and hopefully from that we'll be able to figure out how to deal with it.
That's a very good question, and I'm glad that our elected officials answered first, because this part of the session is about what our elected officials doing about that. And you're right, the pandemic is still with us, and that is what the variant has showed us, that the pandemic, is still here, it's not going away. And so please remember, this afternoon we'll be dealing with the clinical aspect of COVID, so stay tuned for more information regarding that in the afternoon. But what I would say at this point in time, because our chief medical officer is sitting there, is that I don't know if you want to jump in and say something, and is that our concern as a service institution is to continue the appeal to the federal government and our elected officials to do three things. One, you have to keep funding the research, because this is a new disease, and it's evolving with these variants. So money has got to be spent to continue researching to see what's the best approach in eradicating the disease, but also in protecting the people. So that's one thing. The second thing is that we have to encourage that the federal government and elected officials will keep on covering the cost for testing and for the cost of the vaccines. So, and so right now, I think we're shifting away from the testing. And so we're going to encourage it if possible, because you need to know if whoever got infected, what variant it is. And maybe that will give you more information to use in research. So that's my second point regarding that. And the third thing is that we're grateful for the vaccines and how you deliver them so fast to us. And also, they not just gave us the vaccines, but they gave us refrigerators so that we could, because those refrigerators are very expensive. And so we're grateful for that too. So we have to keep the vaccines coming and fund continued community education, because right now we just got a grant from the state of New Jersey, we're grateful, in order to expand vaccination and getting a booster. And the state wanted us to push going into the community for those people who just won't come to the health center or is not available, homeless, everybody. It's a great opportunity for us to try here. So the key here is that we need those funding coming in so that we can give incentives to people and to encourage people to get boosted, and for those who did not get the vaccine to offer it to the people. So legislation is what we need to encourage those three areas.
And I would say also, as an OBGYN, that it is important also to continue to do research, but research within the communities that seem to be hesitant in regards to the vaccine. So some community-based research to figure that out. Why is the hesitancy continuing? And then supporting initiatives to actually work, whatever that answer is, to work against whatever the hesitancy is. It is very important that we continue to do education among pregnant persons in regards to the vaccine. because we know that the numbers for pregnant persons is low. It's in the high 40s at this point. It's even lower for pregnant persons of color. In the Black community, it's in the high 20s, right? And it's in the higher 30s for the Latinx communities. So I think it's important that we continue to educate all the pregnant persons on the safety of the vaccine, regardless of the trimester they're in. It doesn't matter what part of your pregnancy you're in. And also the safety of it while you're breastfeeding, and also the importance of it for your unborn child that will actually gain immunity from you being vaccinated. So I think we need to be able to continue to have those kind of avenues, but we definitely need funding. Sorry. To support those educational fundings that come through, like the Newark Community Health Center and other FQHCs throughout New Jersey. So I think that is important. In any final advice to help women keep themselves, their infants, and their families healthy and safe during the ongoing COVID-19 pandemic?
By the way, Doctor, no need to apologize asking for additional funding. Dr. Clark is always asking for additional funding, and often she gets it too.
My new best friend.
So one thing, by the way, I need to mention before I forget is that pretty soon the public health emergency regarding the pandemic will be lifted, and that could create a problem for individuals who are on Medicaid. And so we want to make sure that all, that everyone who's on Medicaid, especially those who were enrolled during the pandemic, because there was a special enrollment criteria. Once the public health emergency is lifted, the protections that were provided under federal law will go away. So we want to make sure that everyone who is on Medicaid doesn't lose their coverage. So if you are, if you're one of those individuals who enrolled in Medicaid during the pandemic, if you get a letter from Medicaid New Jersey asking you to recertify, letting you know that your coverage may end, please make sure you take care of that. Come here if you're a patient of the Newark community. Come here, and PAM staff will help you because we want to make sure that everyone, especially pregnant people, that they are able to maintain their coverage and not lose it. Again, the federal government is a partner to all our providers, to all our communities. We want to make sure that the resources are available. It's always difficult, to get things through Congress, and there are all these political. That's why we have a great senator in Washington, Senator Booker, who fights constantly for New Jersey, fights constantly for the community health centers. So we want to thank the senator and his staff for the great work they do. But know that you have a resource here. The Newark Community Health Center is a fantastic. It's one of the best, not only in New Jersey, but one of the best in the country. Thanks to Pam's leadership and her tremendous dynamic team here. So know that there's a resource here. Come here, not only to get your health care taken care of, but also any other needs that, and Pam knows this, that community health centers actually do more than just health. Your patients, they become comfortable with the staff here. They're friends You know, a lot of the patients are like friends to the staff, and so when they need help for anything, they come here first. And so that's why it's so important for us at HHS and HRSA to keep funding our federally qualified health centers and keep providing the resources to them that is needed to make sure that then as Hannah said, you know, this pandemic is not over, even though things are improving. But you know, we will always have these upticks in infection. The good news is that less people are dying, even though we have reached or will reach soon 1 million deaths because of COVID. But you know, people are getting infected, and just as much as they did before. The good news is that they're not dying, and that's because we have learned after 2 years. You know, the medical community has learned, you know, how to treat this and how to make, you know, thanks to the vaccine and these new drugs that are out, how to treat people who do eventually get sick. So, so just to wrap up, you know, think of us as a partner who will work with you in any way that is necessary to make sure that the healthcare needs, especially of those who need it the most, especially of those in communities like here in Newark and others in Essex County, who need that healthcare the most and don't have, and otherwise wouldn't be able to get it if it wasn't for a community health center. So thank you for the opportunity, Pam.
I'll let the experts have it.
You said that was the final question?
Yes,
Okay, so you're expecting each of us to say something?
yes.
Oh,
Good.
okay, well, that's why I'm giving it back to Cory.
I know she has something to say, just to
I
find
will,
out,
I'll
yes.
skip the part about advice,
Yes.
for, women who are pregnant, or planning to get pregnant, or just had a baby. Because I'm just a juris doctor, I'm a real doctor. You know, I guess in closing, just would want to really emphasize the fact that maternal health, specifically women's health, is something that Senator Booker has really been a leader on. You know, there's one omnibus bill in the Senate, and Senator Booker is the sponsor of that, right? But it really takes a village. The omnibus bill is a package of 12 bills, and every time we've reintroduced it, it's gotten bigger. And so we're up to 12 now. And so it really is meant to look at this problem that we have in the US. You know, US among its peer nations has the highest rate of maternal mortality in the world. And, you know, specifically the disparities within that, he's really made that an emphasis and something that he's focused on specifically tackling, right? And so that's why you see so much coming out of this shop, Senator Booker's office rather, on this issue specifically. And it comes from, you know, he's not a woman, but his entire kind of senior team, from his chief of staff to his myself as state director, his legislative director, he surrounds himself with women as leaders in his office. And so, you know, it comes from that, but it also comes from his experience here in Newark, right? Seeing firsthand every day the disparities in healthcare and especially for new and expecting moms. And it's kind of created this whole body of work. And we were happy to see Mommy's Act with the Medicare coverage in ARP. We were happy to champion the child tax credit in the CARES Act, which, you know, put money in pockets of families with children so that, you know, you could spend it exactly how you needed it. But all of these things, you know, we're still working to make them permanent. And so with that, you know, I'll just remind folks that these kind of conversations are helpful for us. We learn a lot about what the community needs. It gives us ideas for new bills. But it also kind of lights a fire under us to to work harder to make them permanent.
Is there anything that we as the public can do to help those bills carry through the Senate?
Yeah, I mean, absolutely. You want to, we're, I think, pretty fortunate here in New Jersey in that we have broad support because it's a mostly Democratic state. We have broad support for a lot of the same issues. To the extent that you live in a district or a state that does not, where your representatives are not supportive of these bills, the Mommy's Act, the Omnibus Act, et cetera, definitely please engage with your elected representatives at the federal level to champion these things. And as has been the case whenever there's friction and, just kind of general slow movement in Congress, the states have really picked up the slack in passing their own safeguards and programs. New Jersey has done a wonderful job under Governor Murphy and First Lady Murphy's leadership, and that's wonderful. But that's another thing that we can do. So definitely reach out to your members, talk to them about the bills that you want to see them get on, or talk to them just about the problems that you're seeing in your community, and even solutions that you recommended, right? I loved hearing about the welcome kit that Dr. Clark suggested here for new patients and expecting mothers as a pilot program. These are great ideas. So yeah, thank you.
So my PSA to our pregnant women is don't be afraid, get the help. There's resources out there. We're always here for you. If we don't have the resources, we know where to go. If you don't have a support system, come out. We have our doulas here that will help you through this birth, help coach you, help guide you, help you become a better parent. So come out, don't be afraid, and you will have the best care here at NCHC through our Healthy Start program.
Awesome. And so first and foremost, I want to say thank you to our elected officials and for the federal government, FERSA, for providing the funding for us to do all the things that we do. If they weren't able to go to Congress and to the Senate House in order to get the funding so that we are able to provide those services would be terrible. And especially during the COVID pandemic, we've gotten the PPS monies, we've gotten so much funding for the from the federal government. So I want to say thank you to both of you, and also to our Congressman Payne and Congressman Sears. They really also pushed to make sure that the funding was there. We have a social responsibility in taking the money from the budget that they have given to us in order to hire qualified staff. So at this time, I want to say thank you to our healthcare heroes, every one of us that work here at NCHC, and also the other FQHCs, because we're not alone. All FQHCs work together in New Jersey. And so all the monies that come through from our elected officials and from their fight to get that in the budget comes through to us so that we can hire qualified people. We hire culturally sensitive people. So to anybody in the community who believe that they can do a good job providing service, we encourage you to apply, because as you know, there's a shortage of staffing. And so we're really, really grateful. We want the community to know, please apply. Because if you're good at what you do in healthcare, we're glad to have you here at the FQHC so that you can help us to provide the service and do your mission and your part. Finally, I just would like to say that to the people, they also have an obligation or responsibility, because if NCs and FQHCs get the funding, we hire staff, we have all the resources here. And then because we're a federally qualified health center, we have a sliding fee scale. So if you are pregnant, you will get Medicaid funding. And if it runs out, we also have staff that can help you to qualify for any HMOs or for charity care to the state of New Jersey. We're grateful to the state of New Jersey and Medicaid, because through expanded Medicaid, we can help you to fill out those application forms so that you can help you to cover the cost of your care. So we have all of that. So it's now up to the people in the community to do something, to utilize the resources, come to the health center, bombard us. We are happy. We're glad you come. Sometimes we have a wait time problem and we understand and we apologize for it. But we prefer to have a wait time problem to have no problem at all because people don't come to the health center. So because of COVID, we want to say thank you to our elected officials and to the federal government and HRSA for doing what they do. Thank you to the staff. But we also want to make an appeal to the people, every woman in the community and every man in the community, because every woman has a partner or somebody who is male, whether it's your father, your uncle, your cousin, and it's the woman that brings people to the health center. So the appeal is to the community that they must also take advantage of all of the resources that's available. Once you know, you come in and you demand it. So thank you for asking that question. And that is my last appeal to people in the community. Our doors are open and we have a sliding fee scale. We have an opportunity to help you to find a way of paying for your health care. You should never, never, never say you're not coming to the health center because you can't afford it. Because we have to see everybody regardless of your ability to pay. Thank you so much.
Thank you. In closing, I want to say, and I think you hear First Lady Tammy Murphy say this all the time, we would all like to make New Jersey the safest place for someone to have a baby and for them to then go on and thrive as they are growing up. So again, these types of events are so useful in regards to getting information out to the pregnant persons that need it and their families. As you said, the women are health educators in their families, right? Even if I wasn't a doctor, I'd still be, my husband always looks at me, what's wrong with her? So they're the health educators of their families. So it's important that these, the health centers, the health educators here continue to thrive and be supported by not only funding, but physicians like myself, community-based organizations, so that we continue to work together to make New Jersey the most safest place to have a baby. Thank you again for having this event.
Sorry, I tell you, this is COVID and there's an unusual way in which we're conducting our our symposium. So please remember, this symposium is in two parts. And so we just completed the first section listening to our elected officials. They did an amazing job in telling you what their plans are and what you're supposed to do in order to take advantage of the plans that they do. Come back this afternoon and we'll be talking directly to our clinicians about direct care and what women need to do to make themselves healthier and to have healthier babies and healthier lives in the time of COVID. So thank you so very much and we see you in the afternoon. Okay, see you in the afternoon. Bye. Thank you.
Good afternoon, everybody. Welcome to the clinical session of the 6th Women's Health Symposium here at the Newark Community Health Center. We have amazing guests and speakers this afternoon, where we'll talk about the clinical implications of women's health with regards to the overall comprehensive care for women. We have Dr. Griffiths, Ms. Mary Mackenzie Carey and Dr. Benedict Cacriola, right?
Yes.
Right, Cacriolo. All right. So, but I'll introduce first Dr. Griffin. Dr. Monique Griffin is a professional with expertise in areas of public and behavioral health, who currently serves as Director of Health and Human Services within the city of East Orange. She has worked with interdisciplinary teams within clinical, academic, community, law enforcement, and government settings in an effort to advance a culture of health among individuals and communities. Dr. Griffin assisted in the facilitation of a municipal educational campaign on a need in drinking water, and later served as a member of the New Jersey Water Works led in drinking water task force. It's a pleasure to the podium, Dr. Monique Griffin.
Good afternoon. So I am Dr. Griffith. I'm the Director of Health and the Director of the East Orange Department of Health and Human Services. So first and foremost, I do bring greetings on behalf of Mayor Ted Green. Thank you, Dr. Clark, for the opportunity to participate once again in the Women's Health Symposium. We do know that NCHC is a fixture in our communities, specifically our Essex Metro communities. We appreciate all of the service that you provide to our residents. And, when you call and extend an invitation, I do what I can to make sure that I rearrange my schedule to be present. And that's just, as a demonstration of the ongoing support and appreciation that we do have for you and the team and the work that you do. So thank you for all you do. Thank you for all you've done, even during COVID, because I know that was not easy. And also, we trust that you'll continue to do the great work that you've been doing. So again, thank you. I'm here today to talk about maternal mental health and how we can foster resilience within our communities. One of the items, and I spoke recently even at one of our recent NCHC symposia about the work that we were doing even in East Orange related to COVID. And we know that we were impacted at such a disproportionate rate, needing to ensure that there was access to services, testing, and also vaccines. But one of the things that we know is that there's been a lot of discussion in the recent past, as well as the recent days, about women's health and also options, but also specifically maternal health due to the high rates of maternal mortality, especially within communities of color. In addition to maternal health in communities of color, we can go back to the first slide.
Sorry. Okay.
Being a significant issue, the mental health of mothers in the United States is in crisis. And it's considered to be a public health issue that impacts not only women, but also their children and families. Rates of maternal mortality are key indicators of the health and the well-being of society. According to the CDC, between 650 and 750 maternal deaths are reported annually, and that's conservative. We know that in 2020, 861 were identified, whereas in 2019, 754 were reported. Maternal mortality not only reflects, or does not only reflect, all factors associated with maternal health and well-being. We know that there is also maternal morbidity that we have to take into account. And that refers to the unexpected outcomes associated with labor and delivery, and also results in short and long-term outcomes to women's health. We also know that there are significant illnesses that occur during pregnancy and also after pregnancy that have a long-term effect. Approximately 50,000 to 60,000 women are impacted by severe maternal morbidity. But the wonderful thing is that both are preventable. And we need to start discussing ways that we can prevent those outcomes, those negative outcomes. These charts really do highlight the inequities that we see with regards to maternal mortality, specifically between the years of 2018 and 2020. But what's highlighted are the differences between 2019 and 2020, the years when the pandemic was upon us, and it's still upon us, but we know that the onset of the pandemic is associated with 2019. And so the chart on the left refers to maternal mortality by race, where the first group or cluster reflects the total. The second group references the mortality rate among non-Hispanic white women. The third group references the mortality rates among non-Hispanic Black women. And the fourth cluster references the maternal mortality rate among Hispanic women. And what you can see is that the maternal mortality rate has increased overall, but it's so significant among non-Hispanic Black women. And again, just look at the difference between the maternal mortality rate in 2019, even if we just focus on women of color, and then also 2020. There were significant changes. The chart on the right refers to the maternal mortality rate by age. And so we can see in the first group, that refers to those under 25. The second group refers to those between 25 and 39, and the third group, 40 and older. So again, we not only see that women of color are significantly impacted by high levels or high rates of maternal mortality, but also those over the age of 40. And so when you layer that and these disproportionate rates with the disproportionate rates of COVID-19, and the fact that during the perinatal phase and periods of time, which include prenatal and also postpartum, it's a very vulnerable time for women while they're pregnant, or women who have been pregnant. And so I'm here today to talk about the potential unexpected outcome of pregnancy, or one of them, which is maternal mental health. Maternal mental health conditions are conditions that appear during pregnancy or up to 1 year after giving birth. Depression is the most common. We can go back one slide. Depression is the most, followed by generalized anxiety disorder, OCD, which is obsessive compulsive disorder, PTSD, post-traumatic stress disorder, bipolar disorder, and also postpartum psychosis. Maternal mental health conditions such as suicide and substance abuse are underlying causes for approximately 9% of pregnancy-related deaths. And so again, we look at those periods, prenatal and postpartum periods are the most vulnerable due to physiological and also psychological changes that increase the risk of depression, of anxiety as well. And so the data taken from the Pregnancy Risk Assessment Monitoring System, which is associated with the CDC, shows us and tells us that 1 in 5 women are impacted by anxiety, perinatal depression, so again, across both periods of time, prenatal and postpartum, and also birth-related PTSD. 1 in 10 women experience perinatal depression and anxiety and are more likely to have or experience hypertension. 75% of women are affected, but untreated. And that's so significant because that can actually lead to preterm birth and low birth weight, as well as other complications. So we really need to look at and explore ways of providing support, because this is these are just a few examples of how maternal mental health and poor outcomes can continue to affect women in our community. Next. We know that women of low socioeconomic status are 11 times more likely to develop postpartum depression than those of higher socioeconomic statuses. We also know that they are more likely, again, to experience these challenges and not seek help. Postpartum depression is associated with lower rates of breastfeeding initiation, poor maternal and infant bonding, and also an increased likelihood of developmental delays. All which are significant because these are what provide and identify the foundation to our society. We need women, we need children that are able to truly function within our society. Next. Risk factors of poor maternal mental health include stressful life events, and we know we have all, for the past 2 years, experienced a very, very stressful event, which is ongoing, and that is COVID. But we also know that there are other stressful life events, including racism, right? Including low socioeconomic status and what accompanies that, multi-generational trauma. We also know that when there are stressful life experiences, there's an increased likelihood of perinatal morbidity. Low social support is also identified as a significant risk factor. And we know also during COVID, that was pretty significant. There were many mothers who were challenged due to their inability to draw on their social networks. They weren't able to celebrate even the way that they would typically celebrate. They weren't able to introduce their newborns to their community in the way that they were accustomed to. And due to lockdowns and quarantines and isolation, there was fear. Fear that they might contract COVID, or even that their infant might contract COVID. And so when we look at additional risk factors such as previous histories of mental health, whether personal or families or within families, that added another layer of risk to what women were going through during COVID. We also know that there were many who experienced and continue to experience limited access to care. And when we talk about the social determinants of health, we know that there are existing barriers to care. And women oftentimes or many women were experiencing those pretty significantly. Next. Further, we know that again, we all experienced the collective trauma of COVID-19. It impacted life, it impacted activities, there were losses of life, income, professions. It affected the health and the economic well-being of communities of color at disproportionate rates. And when looking at conditions before the pandemic and after the pandemic, research showed that pregnant women over the age of 18 with no prior history of mental illness reported more anxiety and depression and stress during that pandemic period. So these are relatively healthy individuals, right, with no prior history that experienced an increase. So imagine also what took place with those that had prior histories. We also know that the financial strain due to job loss associated with COVID also exacerbated and predicted anxiety and depression in women who were pregnant. We know that there was a great deal of uncertainty during COVID and even so now, right? I should say during the onset of COVID, right? And even now, because we see the fluctuations in the rates of positive cases. And that uncertainty in pregnant women or women who had just given birth actually resulted in higher levels of depression during and after their pregnancy. And as I mentioned before, there was self-isolation due to fear, where about 35% of pregnant women in their second and third trimester of pregnancy were self-isolating due to the fear of acquiring an infection. Social isolation, fear, for anyone are predictors and risk factors of depression, anxiety, and complications. And so again, we saw it more within women. Next. But there is hope, and we do need to really look at how, as a community, we can bounce back. Opportunities also to be a little more resilient and offer and sustain and support resilience within mothers and women. During the first 1,000 days, which really equates to the birth to 2 years, we know that the fetus and the infant are most adaptable and vulnerable. And it's impacted by not only genetics, but it's also impacted by environmental influences, such as maternal stress, also nutritional state, and social network. So again, imagine what COVID does when individuals are food insecure, when there's a high level of stress, and also when social networks and access to social networks are limited. And while things are opening up, we know that there's still a reluctance to fully engage when we consider some women. And these factors can either lead to or protect from chronic physical illness and mental disorders, even in adulthood. So we know that we're all challenged, but we now know that there is a need and opportunity again to bounce back as a community. We need to foster resilience, and specifically psychological resilience, developing that ability to cope with challenges, stresses, and also adversities. And we do that by identifying strengths, identifying protective factors as individuals and communities. And some attributes or protective factors really do reference and include social support. We need to think about creative ways of bolstering social support. We also need to talk a little bit about self-efficacy. And self-efficacy is really the belief in one's ability to achieve a goal. Can I do this? There are a lot of mothers who are questioning their ability to provide a true level of support for their child and their families during COVID and as it goes on. We can go back to the next one. Also, we know that there is the higher a woman's sense of mastery is, which is their ability to find meaning in a stressful circumstance, adversity, or trauma, the lower their reported anxiety. We know also that self-esteem and personality are key. We're women with a positive view of self and also experience lower levels of perceived stress, anxiety, sleep difficulties during pregnancy as well as after. And when we look at it, we know that there are stressors in life. We also know that there are these attributes. And when we work on increasing the strengths in these areas, that's what's going to lead to these positive outcomes. The positive consequences including a greater sense of well-being, family balance, personal growth, adjustment, as well as an increased quality of life. And there's a saying many, I'm sure, are familiar with, that an ounce of prevention is worth a pound of cure. And we say it a lot. And in this case, the opportunity is really early detection. We really need, and this is where providers come into play, and family and friends can also help. We really need to start detecting these maternal mental health conditions early. And what we know is that 1 in 5 women are not even asked about depression during their prenatal visit. Imagine that. They might be experiencing something, but if you're not asked the question, women may not divulge. And so providers can screen for depression, screen for anxiety during all phases of pregnancy, including postpartum visits. They can also educate, because not everyone understands the difference between baby blues, which might last a short period of time, maybe about 2 weeks, versus postpartum depression, which generally begins 1 to 3 weeks after birth and can impede activities of daily living and even extend up to 1 year after birth. And with postpartum, treatment is usually needed in order to support that resilience. So we need to educate, we need to start talking about it. And I'm actually happy that what COVID has done, because everyone is experiencing some degree of stress and emotions irritability, emotions that they probably never really experienced before or were willing to identify. And so what we're seeing is that the stigma associated with mental health and mental illness is lessening. And this is an opportunity. We need to take advantage of this and continue to educate, because everybody went through it and everybody's experiencing something. Families and friends can also recognize or educate themselves on even the symptoms of depression, anxiety. What does it look like, so that you can help someone who's in need, a mother in need, identify also what's occurring. And we need to encourage women to speak with their providers, individuals who can help, even if they don't know what to do next, and if they don't know how to access resources. Our legislators, and I heard it in the the first part of the symposium, need to guarantee that women receive 12 months of postpartum coverage. It needs to be guaranteed across the board. And we also do need funding, right? We need continued funding also across the board, and also to increase the capacity of the mental health workforce, so that when individuals are trying to access support, they can identify a provider that has room, and they don't have to wait months to see somebody. And then all together, we can provide resources. And there are many, many local resources to be taken advantage of in NCHC. And that's why, again, I mentioned I was so appreciative of this opportunity to speak, to participate, and to show support, because we need our fixtures, we need our FQACs, we need our institutions within the community to be available to provide support for women who are in need, and just residents in need as a whole. And so in sum, we can move on to the next. We need to have and continue to develop a better understanding of maternal mental health and maternal health overall at all stages of pregnancy. And we need to do this because this is what creates the foundation, and the foundation for developing safer approaches to maternal care. And with proper access to care, resources, as well as support, notably during this time, after the onset of COVID-19, we can work to improve maternal health outcomes. So again, Dr. Clark, thank you for this opportunity to be here to speak to this very, very important issue, and also during Mental Health Awareness Month. Thank you.
Thank you very much, Dr. Monique Griffin, for that very great exposition on maternal health, giving us the understanding of what it should be pre and post delivery, and the risk factors or preventive risk factors for maternal health, and points of interventions as well, and areas where and the opportunities that we can use to intervene and create an overall maternal care for our women, and the risk factor, especially when it comes to Black and Brown communities. Thank you very much for that. Our next speaker will be Mackenzie Carey. Mackenzie Carey is the Quality Improvement and Planning Manager of the Partnership for Maternal and Child Health. Oh, sorry. She's gonna be okay. But before Mackenzie comes on, we have Dr. Benedict Caprioli. Dr. Benedict Caprioli is the Director of Gynecological Oncology at Rutgers University Medical School here in Newark, New Jersey. Dr. Caprioli, welcome.
So I'm here for Dr. Einstein, who is involved in some emergency surgery right now. And thank you for the opportunity to come and give this talk, and also to meet you, all the high quality colleagues that I've met today. So what I'm going to be speaking about is cervical cancer screening and the effects of the COVID pandemic on rates of screening. Cervical, next slide, please. I'm going to talk a little bit about what causes cervical cancer, how it's formed, and how it's prevented, and what some of the challenges and opportunities that the pandemic brought forward. Next slide. So this slide shows the rates of cervical cancer mortality across the country, with the dark purple being the highest rates. You'll see that a lot of the dark purple is on the East Coast, along the Appalachian Trail, and then in the West, in some areas where there's not a lot of screening. New Jersey, I believe, is about number 17 in highest rate of cervical cancer. So we have high rates for our population, which is approximately 17 cases of cervical cancer deaths in 100,000. Most of those are, of course, preventable, and that is compared to approximately 7 in 100,000 for the total population of the United States. So our rates in New Jersey are way too high for what I consider to be a completely preventable death. The highest rates are in southern Jersey as compared to northern Jersey. Next slide, please. So what do we have in our cervical cancer prevention toolkit? Next slide. Well, first of all, we have the vaccine, which is considered primary prevention. Why don't we just keep the virus that causes cervical cancer under control? We have pap smears. Pap smears can detect the abnormal cells. It's considered a screening tool. A screening tool is a test that tells us who needs further evaluation. It doesn't tell us who has the cancer, but who needs further evaluation. We have down there on the left is a loop. Electricity goes through that loop. It takes a slightly larger biopsy. This is done in the office under local anesthesia. The women who I perform this on will feel cramp. It usually takes like 5-6 seconds to pass the loop. Very well tolerated way to remove a precancer. And what you're seeing on the right there is a gun where liquid nitrogen passes through and can freeze abnormal cells on the cervix. Next slide, please. So what causes cervical cancer? Well, we know now that most all cervical cancer is caused by the human papillomavirus. And this is an artist's drawing of the human papillomavirus. It's like pieces of Lego that fit together on the outside. That's the capsid. And then inside is the DNA that replicates, invades cells. So the vaccine is made from the capsid, so it's not infective. And this is very similar to the hepatitis vaccine. And for each type of HPV, there's a different capsid or cell protein. In the first vaccines, there was only 2 types of HPV that were included in the vaccine. We now have 9, so we have much broader coverage. Next slide, please. So the way that we think that this works is that you have exposure, and exposure is usually through sexual activity, but it can be through other activities. The skin is broken or abraded, and the vaccine goes into the skin of the cervix or the lower genital tract, which includes the vulva, the vagina, the rectum, and the cervix. And for some people, infection occurs. The HPV that causes the infection on some people goes into the cells and doesn't come out until later in life, and that's called latency. If that infection persists, then it can continue to reproduce and grow and can cause either low-grade cervical intraepithelial neoplasia, here identified as CIN1. CIN2 is sort of moderate, but in a younger age group, we would consider that also low-grade, or high-grade, CIN3. CIN3 is something that definitely does need treating, and as CIN3 continues to replicate, it can break through the cell membrane and go to other places in the body, and that is now considered invasive cancer. And the next slide will show what some of that looks like. So on the left, what we're seeing, let me get to my picture here so I can I do this? Excellent. Thank you. So this is showing some of the infective particles. They go into a break in the skin, and then they infect the cell. Thank you. Here, they'll either stay in the cell or the body will learn how to clear it. And then it will replicate in the cell and cause some abnormal cells. And when it fills the entire thickness, we call that high grade. When it's able to break through this normal cell membrane here, barrier, then it can go in small blood vessels and lymph vessels, and it can spread to other parts of the body. So we have two things now. We have a vaccine that we can use. We can identify it with pap smears. We can differentiate between early and later. We can remove it with a small surgical procedure, which is an office procedure. So now we've got that part. And when it's cancer and we identify it early, it can be treated with surgery, in the later stages with radiation and chemotherapy. Next slide, please. Okay. This is what a HPV looks like under an electron microscope. So we can actually see little molecules, and you can see the little capsid here and the DNA in the inside. Okay, next slide, please. Okay. So who needs a pap smear and who needs vaccines? The American College of, what's IPM? The body that recommends who gets vaccines, the ACIP, recommends that Gardasil, or the HPV vaccine, be given routinely before initiation of sexual behaviors. And so they picked arbitrarily 11 or 12, but as early as 9 years of age. If you've only received one dose, you can catch up with later doses later in life. The quadrivalent and the nanovalent are given at one time, 1 month later, and then 6 months later. There is good data that even if you get 2 of the 3 vaccines, that you have good coverage that lasts a very long time. Next slide, please. The recommendations are now that we vaccinate up to age 45, men and women, because having the HPV vaccine will decrease males' rates of anal cancers, penile cancers, and also they will clear the virus and not be able to transmit it to their heterosexual or their homosexual partners. Next slide, please. So what happened during the pandemic? Well, we saw, like you all saw, people not coming for services. And when screening goes down for all cancers, that resulted in higher rates later of advanced cancers, which cannot be treated as well or cured, where in the early stage, cancers can be more easily cured. So we saw that those rates went down more for Black women than white women, and highest among Asian Pacific Islander women. But the good news is that we are starting to see recovery in screening, and that more women are now coming back for screening. Next slide, please. There have been advances in screening. So I don't know if you know the story of how the pap smear came about. The pap smear was a pathologist in Cornell. He was a Greek immigrant. His name was George Papanikolaou, hence the pap smear. And he got the brilliant idea that if we took a tongue depressor and we took some cells off the cervix, that we could put them on a glass slide and look at them under the microscope, and maybe we could find bad cells and treat those patients early. And that was the first pap smear. For that, he got the Nobel Peace Prize in medicine. That really hasn't changed over decades now, since the 40s, except that we prepare it differently. Now we swish it in some liquid that takes away mucus and bacteria and other things so that we can identify the cells better. What if there was a different way to do this? What if we picked up the HPV? And this study by Dr. Hu et al., I think Dr. Einstein's in here too. Oh, here we go. Here he is. Looked at, could we pick up, could we screen just with HPV? Next slide, please. So this slide says who needs to be screened. Can I ask you to go forward and then go back?
Yes.
Okay, can you go forward to that slide, please? Oh, sorry. Yeah, again. Yes, so here's a picture of how women could self-screen. It's a Q-tip, take it out of the package, put it up your vagina, swirl it around, take it out, put it back in the package, send it into the lab. This has been found in many studies to be an acceptable way for women to screen who don't have the access to providers, don't want to come to providers, perhaps have suffered sexual trauma and are embarrassed or otherwise, and is used very prevalently in Western European countries now, Australia, and New Zealand. Now, if you could go back one. So who needs to be screened? Let's see, I think we missed one.
One more?
Back two. There we go, the recommendations. So these are the US recommendations for who needs to be screened. We do not screen until age 21 anymore. In the past, we used to screen at the initiation of sexual activity. And the reason is that HPV is something that we all get. And most of us, our immune systems learn how to handle or cope with. So at age 21, if we were to screen all of the 21-year-olds who are initiating sex, we're going to find a lot of HPV, and that's going to lead to a lot of unnecessary procedures. And these procedures are not trivial, they can be costly, but also if you have many biopsies on your cervix, the loop or the cone biopsy, then you're at higher risk of preterm delivery later in life. So maybe we should be screening all those people who can't clear the virus. So the recommendations change to not at the start of sexual activity, which sometimes is age 12 or 13, but age 21. And right now, the recommendation is pap smears every 3 years between 21 and 30. And then in 30, your immune system changes, it actually lowers, and we can better identify at that time if you've participated in screening, we pretty much could identify if you've had the virus and it's causing any trouble or not. From age 30 to 65, every 5 years. Okay, next slide, please. Next two slides. There we go. Oops. Back again, one more. One more? Yeah.
Oh, one more, I'm sorry.
Yeah, thank you. Okay, so actually Dr. Einstein is trying to be one of 4 sites that will study self-sampling here in Newark. And we'd like your support for that. We think that this would be a way to help eliminate some health disparities. It would help educate on the importance of screening and the role of screening. And we think we're set up well to run this study, and he's applying for it now. And I can answer any questions that might come through on the chat or any questions anyone here has about cervical cancer screening. Thank you for your attention. Thank you for that.
Thank you very much, Dr. Caprioli. That was an excellent overview of cervical cancer and the risk factors, especially with a conscious relationship with HPV. And the provisions for the U.S. Preventative Task Force recommendations for cervical cancer. Things change, and of course, we have to change with times as well. And to know that, if there's any take-home message, that men and women can get or should get HPV vaccine, and HPV vaccine would result in permanent prevention of the disease. So thank you once again, and it's incredible. We're still on the 6th Women's Health Symposium, the annual 6th Women's Health Symposium here at the Newark Community Health Center in Newark, New Jersey. And we're talking about the risk and factors that pertains to women's health and how to mitigate the factors that result in high morbidity and mortality. At this time, I will call on our third speaker, Mackenzie Carey. Mackenzie Carey is the Quality Improvement and Planning Manager at the Partnership for Maternal and Child Health. She has a master's in public health with a focus on epidemiology from Rutgers University. Mackenzie's QI support member hospitals and birthing centers to analyze the electronic birth certificate data, create regional-wide annual data reports. Outside of the partnership, Mackenzie volunteers at the Glen Ridge Volunteer Ambulance Squad, where she is an EMT over 10 years and works on quality assurance and improvement projects. Welcome.
Thank you. I'd like to thank Dr. Clark and NCHC for having me here so I can talk about the impact of COVID-19 on Northern New Jersey pregnancy outcomes. So a little bit of a background, as we all know, the novel coronavirus, COVID-19, uprooted life in March of 2020. Especially here in Northern New Jersey, it was a prominent hotspot. I think we all know that, and it's easy to forget how much life changed in such a short period of time. Hospitals were overwhelmed with COVID-19 patients. Oftentimes they were on divert, and visitation policies and protocols were curtailed. People were urged to limit hospital visits for only serious emergencies only. If you can remember, we didn't even have COVID tests back then. People were not getting tested for COVID like they can today, where you can just go down to the pharmacy. Next slide, please. So a little bit about the Partnership for Maternal and Child Health in Northern New Jersey. We are a licensed maternal and child health consortia. We are responsible for 4 main things: perinatal and pediatric planning, regional quality improvement, professional and consumer education, and a regional transport system between our member hospitals. We serve the 8 counties of Northern New Jersey, which include Bergen, Essex, Hudson, Morris, Passaic, Union, and Sussex counties. In our region, it accounts for almost 50% of all live births that happen in New Jersey. At the time of this presentation and this study, we had 24 member hospitals and 2 birthing centers. Next slide, please. So our study question was the COVID-19 pandemic associated with changes in frequencies in pregnancy outcomes? Some of our variables of interest that I'm going to be talking about today were out-of-hospital deliveries, maternal and infant length of stay, method of delivery, and then the number of out-of-state moms. We did a very exhaustive study, but these were some variables of interest that we thought people would be interested in, and it actually showed some changes. So this is a retrospective study. The birth data comes from the New Jersey's Vital Information Platform. I'm going to go into more detail about that in a minute. All of the data is all live births that occurred in our 8 counties of our region during the period of January 1st, 2019 through March 31st of 2021. We're going to be looking at the data in quarter segments to kind of break down this large span of time. Next slide, please. So the Vital Information Platform, this used to be New Jersey's electronic birth certificate system last July, in July of 2021. The state transitioned to the Very platform, but at the time that we're talking about, this was our electronic birth certificate system. It was a web-based system for birth registration, prenatal and antenatal data. Inside, I don't think people realize this, but when you give birth in New Jersey, your birth certificate has over 650 fields of health and demographic information. So it's a very rich data source. So we can really look deeply into to see connections. This is administered by the New Jersey Department of Health Office of Vital Statistics, and it includes national birth certificate data fields defined by the National Center for Health Statistics, often called NCHS, and as well as New Jersey specific fields. So there's going to be a lot of data slides coming up. I'm going to just, so it's not too overwhelming, just give you the brief highlights of what I'm trying to show here. So this first graph here is out of hospital births. So when you're looking at that top blue line, that's the one I really want us to focus on. That's the number of births that happen in freestanding birthing centers. So in New Jersey, northern New Jersey at that time, we had 2. We really wanted to see, because of the hospital policies, were women choosing not to give birth in the hospital and giving birth at home or in a birthing center where they might have a little bit more freedom or flexibility. You can also see that if you look at the left-hand side, the number of births, we're maxing out at about 100 births in 1 quarter. So this is a very small percentage of the total number of births that happen in our region at a time. But we can really see that as we go from Q1 of 2020 to Q2 of 2020, that's spiked. Like, that's a very obvious spike that you don't need to be a mathematician or an analyst to be able to see that. That's very clear. But there was also a trend that moms were choosing to deliver in birthing centers prior to the pandemic, and we're seeing that. And that spike has now dropped when we got to the end of 2020 and early of 2021. But it's still in that same trend that we would have assumed it would have gotten to that level if the pandemic had never happened. Next slide, please. Okay, so this is mom's length of stay. So because of the COVID-19 pandemic, moms and babies alike were having shorter lengths of stay in the hospital. As we can see in this graph here, the blue line is for moms who delivered by C-section, and in the pink line, that's moms who delivered vaginally or by VBAC. You can see that before the pandemic in all of 2019, it was about 4 days mom was in the hospital when she had a C-section, and about 2.5, a little bit more, she had a vaginal delivery. We can then see there's a big dip for both vaginal births and C-section births when we get to March of 2020. And then it started to rise again at the end of 2020, early 2021, but it's not at that same level that it was pre-pandemic. Next slide, please. This is a very similar slide. This is talking about the length of stay for non-NICU babies. We only looked at non-NICU babies because if we included NICU babies, we have regional perinatal centers in our region, and where babies may stay for extended periods of time, and we don't have accurate data on COVID babies just yet when we were compiling this study. So we can see that for non-NICU babies, their length of stay also decreased, and it's starting to rise, but not near where it was at pre-pandemic levels. Next slide, please. So this one, you're not going to really see a lot of differences or a lot of changes. So this is the percent of method of delivery by either C-section or vaginal births during the pandemic. You want to see there was a lot of confusing, conflicting information that really came out. People didn't know anything about COVID-19. We didn't know how it passed from mom to baby. We barely knew how it passed between each other. And so we wanted to see, was there any change in the number of vaginal births versus C-section births? Like, we didn't know. But as you can see here, there really was no change. We can see that same consistent 35 to 36% C-section births in our region. Next slide, please. Everybody wanted to know, are moms having less visits with the prenatal visits with their doctor due to the pandemic? We can see there's this really, really slight drop, but we're talking about like a 10th, a 20th of a visit, or like 2/10 of the visit. And also these moms are moms who delivered in March of 2020. their ability to go see their doctor for prenatal visits was not really impacted. So we're going to be doing further research on the moms who became pregnant in the second half of 2020, early 2021, once we get accustomed to the new electronic birth certificate system. The next slide, please. As we also know, there were very strict travel guidelines when it came to the COVID-19 pandemic, especially in early 2021. We were advised not to travel out of state. And so we wanted to see if there was any change in the number of moms who delivered in our region who were from out of state. We do get a lot of moms coming from upstate New York delivering in our region, as well as from Pennsylvania. And as you can see in this graph, it really didn't change. It's slightly under 4% of the moms who deliver in our region come from out of state. Next slide, please. So these are our key findings. So we saw that there was a decrease in maternal and infant length of stay, and we could see that it was a little bit bigger for C-section births than it was for vaginal births. That length of stay is now increasing, but it's not near where it was pre-pandemic. We also saw that the number of out-of-hospital births spiked, especially for the freestanding birthing centers, but those numbers are back on trends of if we had done a model to predict what those numbers would have been like. We also saw that slight decrease in the number of prenatal visits, but that's recovered to near pre-pandemic levels, and we know that with virtual telehealth visits, we're expecting that to be about the same, if not more visits than pre-pandemic levels. Next slide, please. So some of our study limitations. So oftentimes within a birth certificate system, when people are manually entering data, there's a possibility of data inaccuracies. That's a very common thing that we see with our data system. We also have field limitations. We don't have specific socioeconomic variables. We can make generalized assumptions, but we don't have any type of variable that tells us exactly mom and dad's salary specifically. With the old electronic birth certificate system, there was not the ability to add a question that said, hey, does mom have COVID? What's her COVID-19 status? So we really struggled with that type of data because we just didn't know. And that was really big in our region. We also don't have severe maternal morbidity data, very specific variables as well. And that's something that we're working towards and working with the state to develop in the new birth certificate system. One of the key things is we're unable to determine if the patients drove these changes or if it was the providers or a combination of both. Was it the patients who decided that they wanted to give birth in the freestanding birthing centers, or was it the doctors helping drive that change? And next slide, please. So here are public health implications as a result of our study. So this reduced length of stay is really, really important because this may mean that there may be limited opportunities for maternal education, whether that be for maternal breastfeeding, whether that be for postpartum depression screening. And some of these education opportunities might need to be translated into an outpatient setting if patients are not receiving that in the hospital because of the reduced length of stay. This also means that there's a possible shift of severe maternal morbidity to an outpatient setting. If mom had preeclampsia or bleeding or something like that and she's getting discharged earlier, she might not see that until she's at home, and who's there to monitor that? So that's a really big implication of the impact of the COVID-19 pandemic on pregnancy outcomes. So if there's any questions or anything, thank you guys so much for having me and for the opportunity to share our data.
Thank you, Ms. Terry, for that very great overview of the affectation of COVID on maternal birth in the state of New Jersey, especially on the regional level. I mean, it gives us a better understanding how things, fared during COVID. That things we never really thought about. To think that the out-of-hospital births increased, during COVID, and the total number of methods of birth didn't change whether it was C-section or vaginal delivery, and the length of stay, which is a big issue with most hospitals, that the length of stay dipped during those times. I guess most mothers wanted to go home and they took the babies home as well. So thank you so much to our three speakers as we begin to round up the clinical aspect of sixth annual Women's Health Symposium here at Newark Community Health Center, where our goals are accountability, quality care, teamwork, respect, and integrity. And at this time, I will call on the CEO and President, Dr. Clark, to come around up and give us that speech. Thank you.
All right, thank you so much. I'm Dr. Lloyd, who's our Chief Medical Officer. And before we end, we just would like to have a word from our board chair, Dr. Umar Bey.
Thank you, Dr. Clark. Thank you, everyone. It's such a pleasure each year to come and be a part of this Women's Health Symposium. It just makes me so proud of what Dr. Clark and NCHC is able to do for the community, definitely. Another thing I would like to, and if you just allow me a minute, just to talk about a program that Dr. Clark has connected with, and it's a company called OB Healthy. And this company actually is a health and wellness company that has a health and wellness app that is geared towards Black and Brown communities, as well as communities that are medically underserved. And their focus is weight loss. And the reason they focus on weight loss is because these communities, if we could decrease the weight of these communities, we could decrease the incidence of hypertension, diabetes, heart disease, renal disease. All of these problems that are rampant in our communities could be decreased if we could control weight. Understand that, just to give you an example, Black females, if you just take Black females alone, they're almost 60% of Black females are considered either overweight or obese. If we could find a way to really counteract this, then we could do something very positive in our communities as far as health is concerned. Understand that with the OB Healthy app, what it actually is that it's a free app that Dr. Clark has come together, and they will present this app to all the patients of the NCHC. And through this app, they'll be able to connect with that problem of weight loss and connect with the fact that they'll be able to lose weight and bring their health under a better condition. Understand the focus of this is that you should not have to change your way of eating or what you eat or what you eat to be able to lose weight and be healthy. And that's their whole focus. To be able to eat what we love, our cultural foods, and still figure out a way to be appropriate as far as our weight is concerned and to improve our health. And I think this is such a fabulous idea. My background is nutrition, and when I heard about this, I just had to come and talk about it today. So their motto is half the calories is twice the health. And I'm so proud of Dr. Clark and NCHC and being able to bring this company in so that we can present their app to the patients for free, and we'll be able to do something positive for our community. Thank you.
Thank you.
All right, thank you so very much. We had an awesome day. And as I said, during the time of COVID, and we had a very unusual symposium. It's the first one we've had since 2020. So I would like to first thank our elected officials who came this morning. And do remember, we had Congressman Mike Sherrill, we had our First Lady Tammy Murphy, we had Mr. Dennis Gonzalez from HRSA, and we had a representative from Senator Cory Booker, which is Anna Mori. And it was an amazing day this morning where they talked to us about all the changes that is coming down the pipe through the government. And so today we had some wonderful speakers talking about the clinical aspect, as you can see. And if you have your questions coming through, we will respond to them after the symposium, because I think we have to wait for the questions to come through. And so we not only have great partnerships between our elected officials and our clinical people in the community, but I would like to thank our sponsors who helped us. Oh my goodness. And as you can see, that includes Aetna, Horizon, Better Health, United Healthcare, Greater Newark Healthcare Coalition, WellCare, Best Care College, Columbia Bank, and LabCorp. So we're truly grateful. So thank you again. We had an amazing event today. Remember, the healthcare is outside. So do take a look at the different displays on the booths outside, and we're going to continue the day. So thank you to our Chief Medical Officer standing on the right, and our board chair standing on the left. And these are the people that represent Newark Community Health Centers. And we want to thank our staff that did such an amazing job today. We're truly grateful. I just saw one of our staff, which is Ms. Ramos, who sat in the session this morning. We're really, really grateful. And you wouldn't know who's in the back end that did all the work through the corporate office, which includes our chief of staff and our executive assistant. They did an awesome job. And during COVID, our clinical people did an amazing job. So I want to thank all of you and thank you for coming. And as I said, please remember that you must use the services at NCHC. Thank you so much.